Why don't we go ahead and get started? Nikki has arrived, and we have Regina here as well. So this session is breast cancer, the evolution of care and opportunities for improvement. And we have Nikki Jensen, who's the Vice President of Essentially Women, and Regina Hampton, who is a board certified breast surgery specialist and medical director and co-founder of Breast Care for Washington, and some other titles. And I'll let her, if we're going to do introductions, I'll let her do that. But thank you all very much.
Thank you. So hello, everybody. Good afternoon. I am going to share my screen here so you can see my slides.
I need to give you permission real quick. Sorry about that.
No problem. No problem. Excuse me. So I wasn't going to do much in bio, but while we're doing that, I'm a breast surgeon and breast health specialist, co-founder of an organization called Breast Care for Washington, and also co-founder of a store called Cherry Blossom Intimates. So let me...
Yeah, you should be able to share now.
Yeah. Okay. All right, great. So everyone should be able to see my screen. So we're going to just dive right in and talk about the evolution of care and opportunities for improvement in breast cancer. Sorry about that. So I always like to start out with good news when we talk about breast cancer. So the good news is that the 5-year survival rates have just gone up and up and up. And in fact, for a stage 0 or a stage 1 breast cancer, the 5-year survival rates are about 100%, which is pretty doggone good. And that really shows that early detection really is making a difference and truly is saving a lot of lives. When we move down the stages to stage 2, still pretty good outcomes, about 93%. And even for a stage 3 or a stage 4 breast cancer, the rates are not quite as high as this, but in many cases, we can turn it into a chronic illness and add many more lives to women, which is really a big win. Still would love to see a cure, and that research is ongoing. The great thing is that we have less diagnostic tests. So we used to have to take everybody to surgery in order to just make a diagnosis. Now we can just do that using a needle, and that can be done in an office with a surgeon or a radiologist. There's so many newer technologies, and we'll talk about that. And I think the big win for women is the better cosmetic outcomes. And that really is exciting for me as the surgeon. So there's been a paradigm shift. So sort of the old model was physicians were operating in silos. So you'd see one physician, and then you'd have to go find your next physician, probably by the yellow pages, and then later by the internet. But there just was not a lot of coordinated care. And who was stuck in the middle? The patient was really stuck in the middle trying to figure out, well, what's a radiation doctor and how do I find one? And so we moved to a team approach, and this is even actually extended into other cancers beyond breast. But breast was really one of the first to really look at this and say, hey, why don't we work together as a team? And I think, for many of you, you all do a lot of team-based approaches in what you do every day. It just kind of took us physicians a little while longer to realize, we can all play together in the sandbox, and who's going to benefit? The patients. So in its team approach, we see the patient, we discuss with the other disciplines prior to making any treatment decisions. And so this has resulted in more options for the patient and ultimately better outcomes. So navigation has been really important. So again, as I said before, patients were having to find their own providers. They'd have to use the white pages or the yellow pages. For those of us old enough to remember those big bulky books. And so can you imagine you have a diagnosis of cancer and you're told to just go look through the yellow pages to try and find a doctor? It's quite overwhelming, especially in trying to deal with the diagnosis. So what we do is we now navigate, we guide the patients through the care. We simplify this complex maze. We actually help the patients make appointments. We do direct referrals, and this just reduces delays and results in better satisfaction. And again, those better patient outcomes. And it's a multidisciplinary approach. So you can see here, these are all the team members that usually are a part of the decision making for breast cancer patients. So there's the radiologist who reads the film, the surgeon, the pathologist who looks at the tissue, the radiation doctor, the medical oncologist, the plastic surgeon in many instances. The breast cancer nurse navigator and the patient navigator are two of the most important members of the team because they're really the glue that help keep us all in line and help the patient to find resources. We have psychological resources, the lymphedema team, and then we've even added in complementary healers and therapists. You know, as physicians, it took us a long time to kind of take a hold of some of these different Eastern medicine practices. And so we've started to incorporate them into many of our centers. And many of us meet weekly. In fact, my team and I, we met this morning to talk about our cancer cases. And it's great because sometimes we can go back and forth and hash it out. But at the end of the day, we'll come up with one unified decision on how that patient should be treated. And then we're going to present that to the patient. So again, it's about patient-centered care. It's what a novel idea. Not sure why it took us so long to get here, but you know, we put the patient in the center and we revolve around the patient, trying to make this as seamless as possible for the patient because she's dealing with a lot. So let's walk a little bit through just the history of breast cancer surgery because it's quite interesting and fascinating. So in the 19th century, they figured out that in order to cure cancer, that you should get it out, which at that time meant removing the whole breast. And what's interesting about this picture, you can see nobody had gloves on. If we could see their faces, they weren't wearing masks. And actually, surprisingly, they had very low infection rates, which is, I find fascinating. What's also interesting about this is they realized that when you remove the breast, that you had to allow some drainage. So if you look in that lower right, they didn't quite close the skin all the way because they wanted that fluid to be able to have an exit way to get out. And then in the 20th century, a surgeon by the name of Halsted came up with what's called the Halsted mastectomy. And so he still, again, realized that the breast had to be removed. But what he said is that the breast lays on the muscle. And so the muscle should be removed as well. And you can see on the right, quite an archaic way of removing the breast. And what's interesting about the picture on the left, you can see there was no anesthesia. She doesn't have a breathing tube in. So I hope that she at least had, I don't know, a swig of something to help dull the pain and hopefully give her a little bit of sedation during this process. So this is what the Halsted mastectomy looked like. And so it was quite deforming. You know, yay, they were curing the cancer and getting the cancer out, but really left women with some severe deformities. And this is, of course, before doing any type of reconstruction. And so they would remove the muscle. And so you would be able to see the ribs underneath the side where the breast was removed. And what this used to be very deforming, very disfiguring. And women often used to get scarring, so they'd have trouble lifting and moving the arm. So then we moved to the modified radical mastectomy. So still removing the breast in some cases, but what we did is we realized we should leave the muscle there. And so you can see on the left side is the modified radical mastectomy. On the right is the Halsted mastectomy. And so you can see it's a little bit better. You don't see the ribs. The woman has more mobility in her arm. And this really became really important as we move into reconstruction and to move into breast prosthesis, which a lot of women will opt for. And we'll talk about that later. And then about the late 70s, 1980s, someone came up with the idea to say, hey, you know, if the cancer is not involving the entire breast, why are we removing the entire breast? Can't we just remove the lump that has the cancer and leave the breast? And so a gentleman by the name of Bernie Fisher went to a conference, and he was actually laughed out of the room because people thought, oh no, in order to do this right, you've got to remove the breast. Well, we eventually did listen to him because he was right. And so lumpectomy is really considered one of the standard of care. We don't have to remove the whole breast in many cases. We can just remove the lump and leave the breast intact. And then in about the 2010, someone said, well, if we are going to remove the breast, can't we leave the nipple there? Of course, that person was laughed out of the room. And now that's become actually a quite popular operation. It's called a nipple sparing mastectomy. So if you look here, this one of my patients on the left, that's her before surgery. This is a young woman. She was in her 40s. She was diagnosed with one side, and then on imaging, that great diagnostic imaging, we diagnosed a very small tumor on the other side. And so she opted to do bilateral mastectomy. So on the right is her. Those are her nipples. That's her skin. You see, she wanted to be a little lifted and she wanted to be a little bit larger. And all of her scars are hidden underneath the breast and under the armpit. So that's the nipple sparing mastectomy, which really has done wonders. Angelina Jolie, as we all heard of, she's had bilateral mastectomy, and this is the type of mastectomy that she had. So it's great to kind of look at this timeline that in the 1890s, they were doing radical mastectomy. And it took us a long time, about 75 years or so, to even get to leaving the breast intact. Silicone implants came in the 60s and 70s. Chemotherapy was introduced in the 70s. And then you can see in 2010 and beyond, we're up to nipple sparing mastectomies. So the treatment options, surgery, radiation, and medical therapy, which includes chemotherapy and hormonal therapy, are still the mainstays of the treatments. And while I'm not going to talk about radiation and the medical therapy, there have been a lot of advancements when we talk about those. We can do what's called partial breast radiation, where we can, in that lumpectomy site, put in a balloon and deliver the radiation into that site. Chemotherapy has changed over time, and then hormonal therapy, where we can give women some hormone pills after all of her treatment to help keep her cancer from coming back. So breast conservation, back to lumpectomy again. This is where we're just going to remove the tumor, remove the cancer. We're going to remove a little bit of normal tissue around it, but the key is we're going to leave the breast there. We usually will remove some lymph nodes as well. And then these patients are going to get radiation. And what we found is that in this day and age, someone who gets a lumpectomy and has the radiation, their results and their survival is going to be equal to that patient who has mastectomy. And so that's great that women have these options and these choices. But unfortunately, when we used to do lumpectomies, we didn't do such a great job. They were so concerned about just removing the tumor, we didn't leave women with a very functional or even a cosmetically pleasing breast. So you can see here 2 pictures of women who had lumpectomies. What happens is after the radiation, the area scars down, and that's what leaves this dent. So, while we were quote unquote saving the breast, we kind of left women with really bad results. And I remember when I was trained, my surgery professor was saying that we wanted to leave the space open. We wanted that to fill up with fluid. Well, it filled up with fluid and it looked great the first couple of weeks, but after the patient got radiation and that fluid disappeared, it would scar in and leave these awful looking dents. And so we really revisited this conversation about breast conservation. And if we're going to leave the breast, let's leave the breast looking like a breast. What a novel idea. And so we've started to employ this new term called oncoplastic lumpectomy, where we're going to take some methods from our plastic surgery colleagues and even work with our plastic surgery colleagues in order to leave the breast intact. And then we've also taken it further to say, hey, well, if we can do this and leave the breast intact, how about we hide the scar and put it in a less visible place? So there's something called a hidden scar. There's many of us called hidden scar surgeons, where we just really think very carefully about where we're going to place that scar. What I look at and what I think about is, I want this woman to wake up, 5-10 years from now and try and forget that she had breast cancer and not have a scar that reminds her every day. And so this is really the fun part of what we do, is really being able to hide that scar. So in working with our plastic surgery, this is an example of an oncoplastic lumpectomy, where when this woman first walked into my office, I thought about the cancer. I knew I could get the cancer out, but I knew she had always wanted a breast reduction. She's got some droopy breasts. They're a little large. It's probably hard for her to fit into bras. She's probably uncomfortable in her clothes. And so she said, wait, I can have a breast reduction and have the cancer removed. I'm in. Let's do it. And so the plastic surgeon and I took her and did essentially a breast reduction and removed the cancer. So you can see her before picture. The red mark is where her cancer was located. And you can see her after. When you look at her, you can't tell where the cancer was located. It just looks like she had a breast reduction. So this is just one of the big wins. These are some of the happiest cancer patients that we have because they get the breast that they've always wanted. It's still her breast. She didn't have to have a mastectomy. And she looks great. So this is some of the fun things that we do in working with our plastic surgery colleagues. Mastectomy is still a great option. And this is, whereas with the lumpectomy, we're going to leave the breast intact. We're going to remove all of that breast tissue. But what's important for patients to know is that even though we're removing all the breast tissue, there's not a zero risk of recurrence and a zero risk of the cancer coming back. It goes down pretty low to about 0.5%, which is about as low as we can get it. And the reason why it doesn't go to zero is because there's always a little bit of normal tissue right behind the skin. And we have to leave some of that because that provides the blood supply to the skin, very important. But to get down to 0.5%, when some of these patients have a really high percentage, and I always like to use Angelina Jolie's story because she's a mutation carrier. And so although she never was diagnosed with breast cancer, her risk for getting breast cancer was 90%. So with her getting her double nipple sparing mastectomy, she lowered her risk down to 0.5% per year, which is pretty amazing. And then we'll talk about the Cancer Rights Act, because for patients who've had, whether they've had lumpectomy or mastectomy, there are some federal laws in place to protect them. And we'll get into that a little bit later. So when we talk about reconstruction, this can be done in many different ways. We can immediately reconstruct the breast right at the time of the mastectomy. In some cases, we can do part of the reconstruction and put in what's called a holder or an expander. And then we can do the rest of the reconstruction later after she finishes all of her treatment. Or there's some patients who just get a mastectomy and then we do the reconstruction at a later date. And this can be years later. So implants is a popular way to do reconstruction. Implants can be made of saline or silicone. When they first came out, they were all made of silicone. And there were some problems in like the late 70s, early 80s. And so they redesigned them. They made the silicone better so that it's safer and less toxic to the body. And then they found a solution to just fill it with salt water, and it works just as well. So you can see this is a patient here who had bilateral mastectomy, and she had actually nipple reconstruction. So we can do 3D nipple tattooing in order to reconstruct the nipples, or the plastic surgeon can actually reconstruct a nipple using skin from another area of the body. A tram reconstruction was one of the first flap reconstructions that were done, where we're going to take a piece of the woman's body from another place and shift it up. So the belly is great. We all have that little pooch below the belly button, and that actually makes a great breast. And then the woman gets not only the breast done, but she gets a little tummy tuck as well. So you can see this is a woman through all of her stages. The first picture is her native breast and her native belly. You can see her at her second stage where they've reconstructed her, move the muscle and the tissue up. You can see she doesn't have nipples yet in that middle picture. And also to note, the tummy tuck, those is going to be below the bikini line, so she still can go out to the beach and be cute and not have visible scars. And then that last picture shows that she had nipples reconstructed, and then they did tattooing to get the coloring in. Other flaps we can use, we can take not only the muscle, we can leave the muscle, but we can take that skin still from that little pooch below the belly button, and we can remove that, and they can do microsurgery and sew in all those little blood vessels to get the breast mound there, and that's called a deep flap. And then we can also take the muscle from the back and swing that around to create the breast mound as well. So a lot of different options for ladies these days. And breast reconstruction, as great as it is, as there's so many wonderful plastic surgeons out there, unfortunately, there are complications as there are with any surgery. And about 1 in 3 patients are going to have a complication. And about 1 in 5 are going to need additional surgery, whether that be additional surgery to handle something like an infection or the body, rejecting the implant, or just the different stages. As I said, sometimes we'll immediately do part of it and then do the rest of it a little bit later. And then about 5% are just going to fail completely, where we just have to remove everything, whether that be the flap, whether that be the implant, and then just to close everything down and make it flat. Some of the factors and the reasons why are just patient selection. We really have to be selective in the patients that we choose. We have to look at their medical history and be sure if they have any chronic issues, that those are managed appropriately before undergoing the surgery. Body habitus can play a role. Smoking is a big risk factor. Many times patients will say, oh yeah, I stopped smoking, and they really didn't. And then that really puts them at risk for having these high complication rates. And then sometimes it's just psychologically overwhelming for the patient. And so many times patients can just make quick decisions without really having time to think about it. And so we really try to be conscious of all these factors and really try to help the patient and walk her through making the decision that's best for her. But there are some non-surgical options, and that's where breast prosthetics come in. And so a breast prosthesis is a silicone breast-like form that can be used to replace the breast mound. It's usually placed inside of a specially made bra, and you can have a standard breast form, as we see on the left, or a custom breast form, which looks a little more real. So these are samples of custom breast prosthesis. These are made of silicone. We try to color match that patient. We try to match up the opposite breast. And so you can see through these examples, they look pretty real. And so I think it's such amazing technology that we can give the patient back this very intimate part of her body that she's lost through this challenging cancer journey. And you can see here, there's a lot of different color options. I say we're all not one color. We have reddish tones, olive tones, yellow undertones. And so whether you're Black, white, Asian, we can pretty closely color match your skin tone through a custom prosthesis. We can even put in things like moles. We can put in veins. If you have tattoos, we can match up things to the other breast. And so if you think about this, if you had to lose this intimate part of your body, and if reconstruction maybe wasn't an option for you, to have a custom breast prosthesis, we can get pretty close to what you what you were born with. So really a neat technology that we have out there. So what happens when women need to shop for these prosthetic items? Well, typically they would go into a medical supply store, what's known as a DME, durable medical equipment. Yes, the same store where you get walkers and canes and bedpans and porta potties. And many of these places often just have a room in the back. They may have a little decoration. It may just be a room that has a curtain around it. And if you can imagine having to go into this type of place to try and get fit for a breast prosthesis. And so, I personally wanted to change this. And so, I think it's important that those in this mastectomy phase really think about this from the patient perspective. Don't you want to walk in and feel beautiful and know that you're going to be comforted as you go through this intimate setting of being fit for this breast prosthesis? And so let's go back to the Women's Health and Cancer Rights Act. So this was enacted in 1998. It's a federal law that provides protection for all breast cancer patients. And what does this cover? So it says that insurance has to provide coverage for patients. And this is all insurance, whether it be Medicare, Medicaid, even state-run and state-funded programs that are in place under the Breast and Cervical Cancer Program. So this provides breast reconstruction. So if we remove the breast, this says that insurance has to pay for you to have reconstruction if you so desire. It also has to provide reconstruction on the non-cancer side. So you remember earlier, my patient who had that breast reduction and that breast lift, this is why she could have it done, all covered under insurance. It covers the breast prosthesis, the custom breast prosthesis, and the off-the-shelf that I showed you. It covers the mastectomy bra, and a mastectomy bra is a pocketed bra that the prosthesis can fit into. So it keeps it in place so the woman can go out and go salsa dancing and her prosthesis doesn't go rolling out of her shirt and her clothing. And it also covers items that she may need around and after her surgery, post-surgical bras, post-surgical camisoles. And this applies to women whether they've had that lumpectomy or a mastectomy. Again, those early pictures of those lumpectomy patients that had those severe deformities, those patients are covered under this law. They could either get reconstruction or they could get a breast prosthesis. These patients are great for a custom prosthesis to help to cover up that defect so that under her clothes, nobody knows what's going on. There's no time limit. I often like to use my godmother who had breast cancer in one breast. A couple of years later, she developed breast cancer in the opposite breast. She then decided, you know, I'm just going to do bilateral mastectomy. I'm so overwhelmed. I'm not going to think about reconstruction. And about 3 years later, she really woke up and just said, I think it's time for me to go get reconstruction. And she did. And that was about 3 years after she had the bilateral mastectomy. So they could be 20 years, 5 years, a couple of months. This is all covered under that federal law. And if a patient has to pay out of pocket for any of these items, especially the prosthetics or the bras, she should be able to get reimbursed by her insurance. So what does insurance cover? It covers the pocketed bras, and Medicare covers about 12 per year. Many of the commercial payers don't have any stated limits. Usually you have to call and find out what's covered because they're each a little bit different. But again, even Medicaid in every state covers these items as well. It covers a silicone prosthesis, and that's one per breast every 2 years. So if she's just had one breast removed, she can get one every 2 years. If she's had both breasts removed, she's going to get two every 2 years. And this includes the custom prosthesis, except for the Medicare patients. And I'm going to let Nikki talk about that in just a moment. It also includes a non-silicone prosthesis. So there's something called an active form that women can use. So if they're working out, if they're swimming, we don't want them to get that silicone prosthesis. It doesn't hold water. It actually holds on to too much water. And so they get an active form where the water really runs through it, but it still provides her form that she can wear in her swimsuit, or she can go to the gym and wear it under her sports bra and get her workout in. And so with that, I'm going to now hand it over to Nikki, who's going to talk to us more about custom prosthesis.
All right. Thank you, Dr. Hampton. Always a pleasure to get to see you and talk to you. And I'm so glad that all of the people here today get an opportunity to meet you as well. I'm going to share my screen here in just a second. Oh.
Okay, you're good to go.
Okay, thank you. All right, I think I'm gonna get this going here. Are you guys able to see that? Did that work? Oh, 1 second.
That did work.
It's not showing up on my screen right though.
Do you have two screens?
I do.
Yeah. We're seeing the right version, just so you know.
You are, okay. Oops, sorry. 1 second here. It's showing up on the wrong screen for me, so let me get it moved over.
Yeah, it always does that with two screens. But we see the presentation version, not the other one.
Okay. All right. Well, thank you, everybody. And thank you for joining us this afternoon. I'm going to talk about kind of that next stage that Dr. Hampton kind of talked, oh, can you hear me okay?
We can hear you, but now we can't see your screen.
Oh, darn. Where'd it go? Can you see it now?
It's coming up. Yep, looks good.
All right. So as Dr. Hampton had mentioned, some of these things, breast cancer in general has had a lot of advancements over the last several years. And really, it's hard to imagine that it really wasn't that long ago. Really, if we go back to former First Lady Betty Ford, was really one of the first public figures who openly discussed her diagnosis with breast cancer and her treatments. And so since that time, and really, we're talking about the past maybe 46, 47 years, that women have openly discussed and talked about their breast cancer journey. So with that, I'm going to talk to you guys a little bit today about some of the healthcare policy things that come into play and some of those challenges that we're faced with. Oops, it's not advancing here. One second. Sorry about that. All right, can you guys see the next screen here?
Yep.
All right, very good. Sorry about that. So with that, and we're going to talk about this part two and connecting that patient care with patient advocacy. When it comes to CMS, the federal agency that oversees Medicare policy and Medicare coverage, there's somewhat of an antiquated view and perception of what a Medicare beneficiary looks like. And because so many people, so many insurance companies do tend to follow Medicare policy, there is a need to help update this and keep things going as far as keeping up with technology and advances in care that people need to keep up with. So on the left side, we have the Medicare patient that maybe is the CMS perception or the CMS view for what a Medicare beneficiary looks like. It's a very quiet, very sedentary, very very inactive patient that it'd be a Medicare beneficiary. And that really just isn't the case anymore these days. We know so many people that tell us that in their retirement years, they're more active than ever, maybe picking up new hobbies more, maybe women doing yoga, jogging, and, doing those fun things that people enjoy doing. Maybe quite frankly, they were more sedentary in their working lifestyle than what they are in their retired lifestyle. So something to keep in mind with that. Dr. Hampton had referenced the Women's Health and Cancer Rights Act, and this was very beneficial and has proven to be beneficial for women yet today with regards to their breast cancer treatment and coverages. And as Dr. Hampton mentioned, it covers not only just Medicare policy, but really group health insurance companies as well, and those coverages for women of all ages. And when we look specifically at what it allows for, there's some areas that have been very good, and there's some areas that, based on interpretation, have provided some challenges for women. And as it states here, all stages of reconstruction of the breast on which the mastectomy has been performed, surgery and reconstruction of the other breast to produce a symmetrical appearance, and prostheses, treatment of physical complications of all stages of mastectomy, including lymphedema. We know that all surgical procedures since 1998 have been allowed and provided coverage for, as it should be. A physician and their patient should be able to choose the procedures and treatments that are most applicable and most appropriate for their patients. However, when it comes to the interpretation for what is allowed for prostheses, has not had the same and consistent approach to that. So to take a look at that a little bit further, when we've kind of dived into this and really asked CMS why there isn't the allowable for a custom breast prosthesis, they tell us that when they look at prosthetics, they're looking for the least costly alternative. And with that, when we provide to them the explanation and a demonstration of what the difference is between an off-the-shelf prosthetic and a custom prosthetic, they tell us that they don't really see the medical necessity of a custom prosthetic. And that, in their words, when they're looking at prosthetics, also they're looking for that increase in functionality, and they're not seeing an increase in functionality. And unfortunately, based off of women's makeup, beyond childbearing years, a functional breast isn't really necessary. However, it is part of the body. So currently, as we know, Medicare does not provide coverage, and they don't recognize custom breast prosthesis. However, interestingly, the billing code and fee schedule for a custom breast prosthesis was created in 1999, which was 1 year after the Women's Health and Cancer Rights Act. We know then, because of that, custom breast prosthesis, while it wasn't intentionally included as part of the Women's Health and Cancer Rights Act, it also wasn't intentionally excluded, right? So it wasn't intended to be excluded from the Women's Health and Cancer Rights Act. So as we talked to CMS, they asked us for examples of other body parts that they allow as a custom replacement that don't increase functionality. So with that, as we did our research, we gave them the examples of eyes and ears. So I can get a prosthetic eye that looks like my other one, but it doesn't allow me to see. And they don't take an ear off the shelf and just put it on the side of your head and say, well, it's an ear. It's not allowing you to hear necessarily, but you are allowed to have one that helps you be symmetrical, right? And it is customized to fit your need. So as we did the research on this, we really found that when it came to CMS policy or Medicare policy, the breast is really the only body part that's not allowed as a custom replacement by Medicare. So looking at this, I was going to give you a little bit more detail with regards to examples of off-the-shelf and custom breast prosthesis, and Dr. Hampton's examples and her photographs did a fantastic job. But just to kind of further illustrate that, an off-the-shelf breast prosthesis is held in place inside of a pocketed mastectomy bra. And so while that's going to be a great option for a lot of women, there are the limitations. And one of those is that if the woman doesn't have a chest wall that is, that is a comfortable fit, she may have gaps or areas that are rippled or divoted, or maybe she had lymph nodes removed from underneath her arm as part of that surgery to remove the cancer and the tumor. So with that tissue gone, it's possible that women may feel like it's almost like a pendulum where they move and it moves, and it's just not a comfortable. It's just not comfortable for them. Also, symmetry isn't always possible. As Dr. Hampton showed the pictures of women who'd had one breast removed, finding something off the shelf in a prefabricated breast prosthesis really is very challenging to find symmetry for that. We've talked to women who are very obviously not symmetrical, but Medicare doesn't allow coverage for a custom breast prosthesis. So that's really the best they can do and the closest they can come. And then when it comes to skin tone, Dr. Hampton showed the examples of the great options when it comes to skin tones. I always say that this is very similar to, women who might go to the makeup counter. And instead of having one or two color options for maybe their skin foundation to match their skin tone, maybe there's 3 to 4 dozen different color choices for them to choose. And for women who are looking for this to be a replacement of their body part, it's really something that they should be able to do. So obviously then when we're talking about the custom breast prosthesis, it's a scan that's going to be made for an individual mold to be made for that woman to match the contour of her chest wall. So she's going to be able to achieve symmetry, and she's going to be able to match that skin tone to her natural skin tone as well. So really, if we go back and we make those arguments out of medical necessity and, increasing functionality for those women, I know that all of them, compared to maybe the challenges that they might be having with an off-the-shelf prosthetic, I really believe that all of them would be able to make the argument to CMS and say functionality and, medical necessity for them to be able to resume an active lifestyle maybe that they had before. It's really a lot easier to do. Also, for a lot of the women with the custom prosthetic, it's going to that prosthetic is going to fit like a puzzle piece right against her chest wall. And most women then don't need a mastectomy bra after that. And most of these women would prefer to go back to using, regular bras and shopping for those like they did before cancer. So to transition back a little bit, because obviously this is a place where Medicare requires us to pass legislation, right? It's going to require an act of Congress for them to allow coverage for custom breast prosthesis. And so my real thing for you guys today is that having updates in technology and updates, in procedures and things that are available for patients are things that we should continue to strive to do. But we need to know that there are sometimes going to be times where we face challenges. And when it comes to insurance coverages and policies and such, this is worth the fight and worth the wait. So just to give you an idea of the timeline and what all is involved with this, I just wanted to illustrate with this here. So looking at our screen here, the Women's Health and Cancer Rights Act was passed in 1998. It was 1 year later that the billing code and fee schedule was established. It was in 2012, during the 112th Congress, that the first Breast Cancer Patient Equity Act was originally introduced. So this was Senator Olympia Snowe from Maine and Representative Mike Ross from Arkansas, who introduced this bill. That what it did was quite simply, the only real action of it was modifying the Social Security Act to allow custom breast prosthesis as an eligible option for Medicare patients. Now we know, looking at the Social Security Act and Medicare patients, we do this because Medicare policy is something that a lot of other insurance companies tend to follow. So as long as we can change Medicare policy, those insurance companies that may also follow Medicare policy would follow suit as well. So unfortunately, in 2012, the bill was not passed. Neither Representative Ross or Senator Snowe came back into the 113th Congress. And at that time, there wasn't anybody really to kind of pick it up from there and get the bill reintroduced. It was in 2018 that myself and my organization became involved with essentially women and the pursuit of this bill. And so before we reintroduced the bill, we went and we met with CMS Ombudsman and we asked them to take another look at this and ask them if they could make a regulatory fix, meaning could they just change their interpretation and allow coverage for custom breast prosthesis. At that time, they told us that they would not be able to do that, that it would require Congress or legislation in order for them to provide coverage. So that's where in the later part of the 115th Congress, we reintroduced the Breast Cancer Patient Equity Act. And then we did not get coverage. So that was very much in the later stages of the 115th Congress. And then in 2019, in the 116th Congress, it was reintroduced again. As we all know, 2020 was kind of a crazy year, and we were not able to get coverage for that. And it was just within the last few weeks that we did have the bills reintroduced again in both the House and the Senate to again try again for coverage for the custom breast prosthesis. So to give you guys a little bit of an idea, and I know that before I really started working on this, I didn't have any idea how some of this healthcare policy came about as far as wanting to change things and the amount of effort that goes into changing. So I thought I'd give you guys a little bit of a civics class brush up refresher for you this afternoon, just to explain what all goes into this, but to tell you that it is possible. So right now we are in the 117th Congress. In the House, we have HR 3087 as our bill. In the Senate, the bill number is 2051. In the House, we have Representative Judy Chu, who is a Democrat from California. She sits on Ways and Means Committee. That's what the WM means behind her name. And then Representative Jackie Walorski, she is a Republican from Indiana, and she also sits on Ways and Means. Now, it's important to us that we have this as a bipartisan bill. We do not want breast cancer to be considered partisan, so we have both a Democrat and a Republican as lead sponsors. And Ways and Means is important because Ways and Means has jurisdiction over Medicare when we look at making policy change. And so Ways and Means and Energy and Commerce are really the two committees within the House of Representatives that have jurisdiction over Medicare. In the House, there are 435 members. Our goal and our objective is to get over 218 House members to sign on as co-sponsors to say that they would vote in favor of this bill. So in order for us to move this forward. In the Senate, again, it's Bill 2051 right now. We have Senator Tammy Duckworth, who's a Democrat from Illinois, and Senator Lisa Murkowski as a Republican from Alaska. Now, Tammy Duckworth is a great advocate for us. Those of you who may not be familiar with Senator Tammy Duckworth, she is an Iraq war veteran. She was a helicopter pilot who was injured in combat, and she is an amputee. She is a very strong advocate for amputees in the orthotics and prosthetics area. And she fully understands how important it is to have a customized prosthetic to your body. And so with that, she's been a very strong advocate for us, excuse me. And Lisa Murkowski is on the HELP committee. So HELP is the Health, Education, Labor, and Pensions Committee. But ultimately in the Senate, it is Senate Finance that has jurisdiction over Medicare. In the Senate, we have 100 senators, and so our goal is to get over 51 of those senators signed on in support of this bill to help move it forward. But ultimately, we know at the end of the day, grassroots advocacy is the most important part of getting bills passed. Advocates are who passes laws. It's very important for our legislators, our lawmakers, to be able to hear personal stories directly from their constituents. And so this was in 2019 that some of these pictures were from. Obviously in 2020, we weren't able to do any patient advocacy efforts, but these were a couple of the events that we held. The left side was from Chicago at the Second Act office or mastectomy boutique. And then the one on the right is from North Carolina in the Greensboro area, where we had opportunities for patients to come and tell their stories directly to their lawmakers. In that picture on the left, you'll see Tammy Duckworth there, Senator Duckworth, there with the patient advocates, telling their stories. So our goal and our objective with this then, in order to pass this bill and really change healthcare policy for women to have access to custom breast prosthesis, is we need these stories and these kind of things to happen across the country, and that all legislators have an opportunity to hear this. And so with that, just some of the advocacy efforts that we work on, because for us as essentially women, we are a membership community. I don't think I mentioned that at the beginning, but we're a membership community for mastectomy fitters across the country, listening to some of the things that their patients need, right? And help to bring those to the surface and get them out, things like this in front of the legislators. So we created an advocacy campaign called Let Her Decide, because ultimately at the end of the day, this bill is about making sure that women have the options available to them when they need them and if they need them. We know that 1 in 8 women will be diagnosed with breast cancer in her lifetime, but nobody really knows until they're faced with a decision or faced with a situation that, what option they may need. We know surgical reconstruction is a great option, but some women may be told that they're not a good candidate for surgical reconstruction, or maybe they may choose not to have additional surgeries. For those reasons, then when it comes to prosthetics, we want to make sure that they have the choices available to them that they may need. So we have this site, letHerDecide.org, as an opportunity to educate people and then take action. When people click on that Take Action Now button, it takes them to a page where they enter in their zip code, and it pulls up then their legislators, so their senators and their representative, and it has an email drafted that will send an email off to their legislators. So again, these are very important and very critical. We also encourage people, if they even just want to pick up the phone and contact their legislators to let them know that the Breast Cancer Patient Equity Act is an important thing for them to have passed. And so with that, again, my takeaways for you guys, I want you guys all to know that we should continue to innovate, right? We should continue to look for ways to improve patient care. and things that just make things easier for people. And at the end of the day, when these challenges are faced in front of us, that we don't give up. Understanding that we're all influencers, right? So whether it's within the jobs in the community or in the companies that we work for, or the communities that we live in. I know I don't necessarily, when I hear the word influencer these days, I do not consider myself an influencer when it comes to social media or anything like that. But I will tell you that all of us, right? All of us need to acknowledge the fact that we have the ability to influence others, and we have the opportunity to make things better for those around us. So with that, I'm going to open it up for questions. And on behalf of Dr. Hampton and myself, I thank you guys for your attendance today and your attention. There's Dr. Hampton back again. So thank you guys so much. We greatly appreciate you. And any questions you guys may have for either one of us, we're here and willing to take your questions.
All right, I have a quick question, just kind of on the, on the legislative side. I spent some time working on Capitol Hill back in a previous life, and how unusual do you feel it is to have, take so long to get something passed? It seems like you're, get 100 sponsors, co-sponsors. It's a pretty good indication that it's a good bill. But how unusual is this?
Yeah. So, for it taking this long, I look to, our government people that we work with. And when we first got started with this, I mean, this seems like such a no-brainer, right? When we talk to people, the health staffers and the legislators themselves, and even medical professionals, people are very puzzled as to why this isn't something that would have been covered before, right? Why do we have to advocate for legislation for this? And it is frustrating. However, then the people I work with from our government department, they always remind me that really, regardless of what kind of legislation it is, it usually takes 10 years to pass a bill, which is really frustrating, but it's also really very much real. And we've seen that time and time again with lots of different things. I think of the Lymphedema Treatment Act. If anybody's familiar with that, lymphedema garments. They are, I think, considered the most supported healthcare bill in Congress. And they, I think, are in year 11 right now and trying to get passed. So it's just one of those things where you just have to stay on top of it. Be a squeaky wheel.
Right. Absolutely. Any other questions?
I'll just ask a quick question. You guys, this was great. And I put something on the chat window to this effect. What I love about this is it kind of gives us inspiration about what we can be all the way downstream. This has been something that's been worked on for a very long time. A lot of our membership is people who are working on very early stage companies. And so I wonder if you can give them just a couple of quick bites of advice to say, okay, we know you're facing a barrier in terms of access, or, I'll give an example from my own past. The remote monitoring was not a thing, 15 or 20 years ago. Just any recommendations for them about to kind of encourage them to, keep the long game in mind, but that there are milestones that you can hit along the way.
Yeah, I will say persistence is the key. I think that being driven by purpose and passion is the biggest thing that you can do. And then surround yourself by the people who have that same purpose and passion, and never give up, because there's going to be a lot of people along the way that are going to tell you it's not worth it and it's never going to happen. And you can't listen to them. You have to just keep pushing forward. I can't imagine where we'd be right now if we didn't have that, the remote part that we've, this, right? All of this that we've all been using over the past year and a half. So it's certainly something that you have to stay driven.
Yeah, and I'll just add, if there is a need there, just know that whatever you're creating is going to meet somebody's need. And you may not find that person immediately, but if you just keep pressing and pressing, you'll find it. My personal journey, people thought, oh, well, you're just a surgeon. Why are you going to be a mastectomy fitter and open a store? Well, I saw a need in my community where women who needed prosthetics, they didn't really have a place to go. And so we just kept pressing and thought, let's do it a little bit differently. And so it gets discouraging at times. But as Nikki said, you just keep pressing forward.
Thank you both so much. I really enjoyed that.
Any other questions? Okay, well, we will end this presentation then. I really appreciate Nikki and Regina. For those that are on the line, we still have networking reception here scheduled that you'll need to leave this and go into the application and click on the next one. But we hope to see you there. With that, thank you all very much.
Thank you all so much for joining. I hope to see you in the networking reception when you can have a personal interaction with several of our panelists. All right.
Thank you.
All right. Bye-bye.
Bye for now.